Hello, I'm Dr. John Keiseb, a gynaecologist in Windhoek, Namibia, in fact in the whole country of Namibia. And today I'm excited to share some clarity and some light onto some myths and conceptions and some areas of concern that women may have regarding birth control methods, family planning, and contraception. Birth control methods can be classified or divided into a few categories. There is male methods, believe you or not, and for males, and then there's female methods. The male methods commonly is abstinence, use of condom, sterilization, and an old-fashioned method that is called coitus interruptus. For female methods, we've also got a bit of categories. We've got abstinence. Number two, conventional methods, which we divide a bit into natural methods and barrier methods. So if we talk about natural, these are sort of non-hormonal methods. I mean, examples, just to give a few examples, would be the body temperature method, symptothermal method, ovulation pain method, and lactation. Breastfeeding has been used naturally also as a means of contraception. So those are a few natural ones. Another one would be the cervical mucus method. All right, so that's natural. Then we've got barrier methods. That means, barrier. That would be sterilization in ladies, diaphragm, and obviously the condoms with the spermicides. Then we move on then in ladies to the hormonal methods, which is divided into oral contraception, which can be only progesterone or combined methods, or injectable contraceptions, and the intrauterine contraceptive devices, which could be either non-medicated like your copper devices or the medicated ones. Then we've got subdermal implants that you put just under the skin on the left arm, like your implanons, your norplans. And you've also got the transdermal method, which is your patches, all right? And lastly, the other category could be spermicides, which is really an old method where a chemical is put around the vagina after coitus to prevent the sperm, to be toxic to the sperms. We don't use that when they because of better methods available now. And lastly, emergency contraception, which can be either using an intrauterine contraceptive device 5 days after unprotected coitus, or even using just a progestin-only pill, which is within 72 hours, or even a combined method of tablets. But those are all birth control methods that's available. If you look at various methods, some are highly reliable, some are very reliable, and others are less reliable. If we can just categorize them, highly reliable methods mean the failure rate is less than 0.5%. That means the effectiveness of the method is about 99.5%. All right, and those would be your DEBO, the sterilization, and intrauterine contraceptive device. That's how good they are. Then you've got very reliable methods, which is the combined pill and the transdermal patch. Those ones would have a failure rate of about 1%. That means they are effective up to 99%. And then the last ones, the progestin-only pills and the condoms, the effectiveness is failure rate is about 2%. That means they are 98% effective. So yes, some are more effective than others. There's some few practical considerations we use. I think the first obvious one is you want to look at the duration of protection, that the patient desires. We also look at the religious myths, concerns, cultural norms. We also look at other coexisting diseases that could contraindicate the usage of any method. And then we also look at the patient's educational level and intelligence. because all those factors and the fact that they can use the method and they can understand the usage of the method. So all those considerations are used as we counsel and advise the patient. If any method is started on the first day of the menstrual cycle, they are really all effective immediately. That would really count for the pill and for the injectable contraceptions, as well as for the intrauterine contraceptive devices. But if you look at the pill and the injectables, if they are not used or started on the first day of the menstrual cycle, then additional protection is required, and we would normally counsel the patient or the couple to do something extra like usage of a condom for a period of 14 days. But otherwise, most of them would really, if used correctly, as I explained, effective immediately. Yes, the answer is yes. As you know, nothing is 100%. I mean, we use these percentages also for the lawyers. But you can. Now, we really talk about, that's why I talked about the highly reliable ones, because those ones, the effectivity is 99.5%. You see, that's your injectables, especially the Debu, that's your sterilization, and that's your combined, the intrauterine contraceptive device. Okay, so there's that 0.5% failure rate. And then you've got the very reliable ones, where that's the pill, the patch, the combined pill, the patch, and those ones, the failure rate is about 1%, so they're 99% effective. And then the progestin-only pills and the condoms, about 2% failure rate, they are 98% effective. Okay, but having said that, we talk about two important concepts here. We talk about theoretical effectiveness, and that's the method effectiveness, versus and/or the user effectiveness. So let's talk about the method effectiveness. That would mean that considers the number of pregnancies that will occur if a woman has used the method correctly and regularly. Okay, that's a method effectiveness. Whereas the user effectiveness would consider the number of pregnancies that will occur if the woman does not use the method correctly and regularly. So that means the failure can occur either because of the patient or because of the method. Okay, so for instance, if you take the pill, the theoretical effectiveness of the pill is 100% almost. I mean, we talked about it, 99.9.5. But the user effectiveness depends now on patient error. She's not taking it, she's forgetting it, she's not taking it at the right time, she's got diarrhea, so it's not getting absorbed nicely. Other medications she's taking that interferes with oral contraception, that will interfere how effective the method is at that point. So yes, that can happen, but the chances are really very slim. Chance of a woman to fall pregnant having used birth control for a long time is as good as a woman who has never used the birth control to fall pregnant. They did a big study. This was more for combined oral contraceptive pills, basically a 3-year study that involved over 3,700 participants, and they found that even with long-term usage, the chance of that happening was basically negligible. But the other factor to consider is the return of fertility, the onset of return of fertility. So let's take a normal couple that's just staying together, having sex the way they feel like. Chances of falling pregnant, they could take up to 5 months. We know that generally. So therefore, once you have now used a method and you have discontinued the method, there is a delay also in that onset of pregnancy. Now, on average, we found that with the pill and the patch, the delay of that onset is 5 months. With the intrauterine contraceptive device, that delay is also about 5 months. With the Debo injection, that delay is around 9 months on average, and with the Neristrate, the other form of injection, it's about 7 months. Condoms would be the same, like once you have stopped the condom, like couple not using anything, so that would be around 5 months. So that's sort of the ease, yes, and expected, but we got to warn patients that don't use that now as contraception. That's what I often advise my patients, because they will think, oh, doctor told me I can take up to 9 months to fall pregnant, I'm okay. Then they don't look for another method and they get into what I can call trouble because they were not ready. Depo-Provera is one type of injectable contraception, a very highly reliable method, which is given every 3 months to patients, and the contraceptive cover is really almost 99.5%, so it's got a failure rate of 0.5%. The issue of side effects should be addressed before commencement of the method, including Debo. So once a patient we embark on birth control method, family planning method with a patient, you've got to sit down and give them advice and counsel them on possible side effects that can occur. And we do that in a reassuring manner, so that she is aware of possible side effects and she's able to accept them much more better, and she's not able to have irrational thinking when should they occur, and have fear around what's happening to me. So that initial counseling is therefore very important. Not just, okay, I want Debo, sit down, give the injection. And many times we found that and if you look at common side effects that they come back and complain, would be irregular bleeding, could be loss of period, which we call amenorrhea, weight gain, as you have asked quite correctly, very common, things like loss of libido, vaginal dryness, a little bit of depression can occur from time to time too. So those are the common ones that we find with Depo-Provera. Now with the weight gain, which is really quite a big concern for the ladies, it's not that because the hormone is in your body you gain weight. What it tends to do is it's increasing appetite. So you like to eat a little bit more. So your counseling therefore should be, look, watch your diet, watch what you eat, and so on. And the weight gain is estimated to be on average around 3 to 5 kilos. So if somebody's already got a weight problem, you got to consider, is that the best method? Can I think of another method? Will they be able to control their diet? All right. And if not, probably think of another method. It's basically a transdermal form of administration. So all that happens is the lady is putting the commonly used one in our market and available is the Evra patch, which is working the same way like the combined oral contraceptive. It's got both progesterone and estrogen. And the key to that is you got to put it weekly on the same day of the week for 3 weeks, and then you've got a patch-free period, and then you start over again. If you start it on the first day of the period, again, as I indicated, the protection is immediate. If you're starting it any other different time, then you've got to again advise them to 14 days of protection.